Hello everyone and welcome to this session. It's such a pleasure to be here with you today talking about such an incredibly important topic. Improving lives and reducing disparities. How we can make every interaction count in primary and secondary care. How we can build community capacity to meet people where they are. How can we reduce inequalities? And how can we achieve really effective secondary prevention? That is, to detect disease at a sufficiently early stage that you can stop it in its tracks or slow its progression. With the pressure that the NHS is currently experiencing, this is a particularly timely question, of course. And frankly, it's going to be incredibly important to hear what our speakers have to say. So we're going to look at this from a few different angles based on different sectors and settings. And let me introduce the people who are going to have different examples, different experiences, and different perspectives of how we can actually advance secondary prevention at the intersection between primary and secondary care and into those different sectors. So let me introduce our 5 brilliant speakers today. The first one is Dr. Christine Ikechi, who is consultant obstetrician and gynecologist and Women's Health and Equality Advisor at the Race and Equality Task Force at the Royal College of Obstetricians and Gynecologists. Then we're going to hear from Dr. Emily Lawson, who is Chief Operating Officer at NHS England. Then we shall move to Jacob Lant, who is CEO of National Voices. And we will conclude with Dr. Aruna Garcia, who is a GP and medical advisor for networks and partnerships at Leicester, Leicestershire City and Rutland Patient Care locally. Each of them is going to have 5 minutes to share their insights with you on different aspects of this really fascinating topic. And while you are listening, ponder your questions. Here are your options. You can think of a question and put it on Slido. 2 ways of doing it. One is find it in the app. One is, I think there's some kind of QR code somewhere to scan. Don't know where it is. Maybe it'll appear. So pop your questions into Slido, and if you're on those Slido questions, if somebody else has asked the same question as you and you particularly want to answer, then do just like it rather than repeating it, because that makes it easier for us to spot it. And if you're not feeling Slido inclined, then there will be microphones as well. So many opportunities to take some questions and ponder this at more length. But for now, let us move to our presentations. And I'm delighted to welcome, first of all, Christine Ikechi.
Thank you so much, Leila, and thank you everybody for joining us today. So in 5 minutes, maybe I'd like to take us all on a little bit of a journey. And that journey takes us over the past 4 years. The past 4 years, of course, we remember 2020 and the start of the pandemic, but equally at the same time, the start of a more serious conversation around health inequalities, and particularly health inequalities when we look through the lens of race. But I use this juncture to point out that health inequalities is not just racial inequalities, but also looking at gender inequalities, sexual orientation, disabilities. But when 2020 started, I, together with then the president of the RCOG, the Royal College of Obstetricians and Gynecologists, and the vice president, we created the first Race Equalities Task Force. And really the aim of that was for us to address this issue at source, particularly through the lens of maternity. Now, over the last subsequent 4 years, there's been so much attention around maternity and what's described as maternity scandals, rightly so. But we could see that Black women in particular were more likely to have worse health outcomes, and following the work of Michael Marmot, that those people who are at the lower sections of our society also had worse health outcomes. So there was lots of attention, lots of pledges for money, lots of pledges for support, but where are we now 4 years later? What I would say is that 4 years later, we are still talking. We know that there are huge data gaps, but meaningfully, have we been able to make some change? Now, I wear numerous hats. I sit on the NHS Race and Health Observatory. My colleagues are talking in another panel, but I'm glad you've all come to us today. I'm also a chair of a number of charities. And one of the things that we have learned over the last 4 years is that secondary prevention is incredibly important if we want to address inequalities. And we have examples of best practice. So best practice would include cervical screening. We know that with cervical screening and HPV vaccination, we have been able to prevent up to 70 to 80% of cervical cancers. This is a huge win. Another great example is maternity antenatal care, when it used to occur in the community. The whole purpose of antenatal care is to screen women to identify concerns for the mother of the fetus that may move them from a low-risk pathway to a high-risk pathway, and potentially could impact on their morbidity and mortality. However, these are very few examples of best practice. So I also have a health policy hat on, and one of the big pieces of work that I'm working on at the moment is fibroids. There's been lots of talk about women's health conditions, particularly endometriosis, PCOS, and of course menopause. But there are so many other conditions that are not heard of as much and yet has as high a burden, or maybe even bigger. So working with Health Economics Group, I created this huge project based on an assumption that I realized was incorrect. And that assumption was that there was a good data quality data set, essentially, that identified women who were referred from primary care into secondary or tertiary care with heavy menstrual bleeding, the main symptom with which fibroids present. And could you believe it, in 2024, that data set doesn't exist. It doesn't exist locally. I thought that maybe was an issue with where I work. But then as I tried to look for this nationally, I found that that wasn't the case. So it meant that all of my grand ideas about using AI and tech and helping community engagement has almost fallen to the wayside because I cannot prove prevalence of disease. And whilst there is lots of data around the prevalence of disease, it's on different communities, namely American populations. And when there's a lot of talk around disparities, erroneously people will use American populations and try to use that to explain Black or Asian or other populations in the UK, and that is incorrect. So to sort of come back round and say, when we're talking about secondary prevention, when we're talking about reducing disparities, how much do we really mean by this, and how much are we really engaged? And we are in a technology scenario, and yet within healthcare we know that sometimes we are quite slow to adopt technology and data and AI in a meaningful way. So what I mean by that is that we get very excited about technology and data, but often we're not very clear about the question that we want answered by technology and data, how data and technology can help reduce all types of inequalities so that we can improve overall the healthcare for all of us sitting here today. And if we don't have that, then essentially in another 4 years, we may be having the same conversation, which I don't want. So I throw this out as well. I've been meeting quite a few people today, trying to build very good networks and connections, because those of us that are on the ground, clinically and also working in management and policy, do understand what is needed, do understand how to use this data that we do have well, but need people such as yourselves and my colleagues on the panel to make that work.
Wonderful. Thank you so much, Christine. And now we are going to move to our second speaker. So over to you, Emily Lawson.
Thank you very much. So I will also make a transition from the pandemic learnings, I think. So I will come back to it potentially in questions as we discuss, so rather than dwell on it. But I think I got my first taste of how possible it is to do what we're all talking about on the panel through the pandemic, particularly through vaccines, where we were able to do, I think, 3 things well. The first was to deliver patient services safely to meet patients where they were. The second was, in doing so, to address inequalities, and the third was to improve operational performance. And so my goal I set myself when I started this role in November was to say, how can we do all three of those things simultaneously, or how can we, as NHS England, support people to deliver this locally? Because what I've heard, particularly through planning meetings over the last month or so with ICBs, but also in the visits I've been able to conduct and the conversations I've had with people nationally, I can see that there is a huge amount of local innovation going on that pulls those three things together every day. And riffing off Amanda's speech earlier, which I'm sure most people have at least thought about, if not heard the whole of, our challenge is to take that local innovation and scale it. That my observation when I first joined the NHS 6.5 years ago was I was astonished and slightly worried by the fact that innovation was frequently neither sticky nor viral. And I think we got better at that. I think there are some areas where we're better at it than others, but my mission as Chief Operating Officer, and something I think I can really help with, is to figure out how that brilliant local innovation, we can support it in scaling up more quickly. I recognise I never will have all of the answers on that, so again, I'll put that challenge back to you when we get to have a discussion about it. So as that learning from the pandemic occurred, the recovery plans that were written inside NHS England for delivering safe services back to where they should be, meeting people where they were, that inclusivity has at least been attempted to be designed into those recovery plans from the beginning. So building on the work of the Health Inequalities team, and obviously led so effectively by Professor Olabi, and building the core 20+5 approaches into all of the recovery plans as far as possible, meeting people where they are, making every contact count. So what I wanted to do was to talk about just some of those innovations that I've seen at the front line and help us think about how do we do this more? How do we both support that local innovation and scale it up? So to give you some of those examples, if we take first the elective programme, which has had huge success nationally, but taking it down to the local level. For example, at the University Hospitals of Coventry and Warwickshire, they've developed the HEART tool, which I don't know if anybody in the room is familiar with, and that uses clinical, social and demographic information alongside waiting times to prioritise patients based on their needs, recognising that those who are living in the highest deciles of deprivation may be suffering greater acceleration of their disease as they wait. So this tool enables clinicians to identify those individuals and recognising they may have struggled to access services in the first place, and bring them in at the appropriate time for them before more acute deterioration in their condition. That's backed up by an ethics board to make sure that there's no inappropriate prioritisation of a particular group of patients. And just in the 3 months after introducing the tool, the Trust had reduced the number of 52-week waiters by a quarter. And the waiting list has continued to move in the right direction. They're one of our leaders in the current process to eliminate 65-week waits. So that example of using an inequality tool to actually help improve operational performance, I've found to be hugely inspiring. Another example from the UEC recovery plan, even built in nationally to that plan, was that poor levels of UEC performance have a disproportionate impact on those who experience health inequalities. And just local to here in Stockport, the team set up a high-intensity use service in its A&E department, which looks at the 100 people who come to A&E most over a 3-month period, and then offered them additional support. So that includes all kinds of support, including non-medical life challenges, social, emotional and practical help, and in particular joining up care across different NHS services, including mental health support. And just to give you a sense of the operational impact, one patient who's been part of this help had previously attended the emergency department 80 times in 12 months, which had resulted in 12 non-elective admissions. Overall, that high-intensity use service is estimated to have had over 300% return on investment. So it's not just operational performance improvement, it's actual value for money on the ground. So just taking that and the elective as an example, that is a direct improvement on both individual and a group of people's lives through improving operational performance. And if we think about then children and young people, where we know there's been an enormous increase in demand for services, and where for children it's not a case of an NDA for an appointment, it's that they were not brought, right? So we have to think about the whole family environment. So the Children's Hospital Alliance, a network of the biggest paediatric hospitals in England and Wales, piloted an AI tool that would identify children most at risk of missing appointments. And those children, fairly obviously, disproportionately come from families in the lowest deciles of multiple deprivation. And Alder-Hey Innovation Unit has developed the Was Not Brought tool. And in implementing that tool, they achieved an 80% degree of accuracy in predicting missed appointments, and allowed a whole range of trusts to implement changes such as transport support, and scheduling appointments in the appropriate slots that families could meet, because often with parents on 0 hours contracts, and including things like appointments in schools, so that the appointments were just much more accessible to children and their families. Prior to those pilots, patients had a non-attendance rate of 68%, but through the targeted intervention, that's dropped to 16% over the course of the 2-month pilot, so a dramatic improvement in access for those children. This also extends to shifting activity out of hospitals, which has been a focus which Amanda also mentioned. Specifically in community mental health, we'll know that serious mental illness, SMI, is one of the core 20+5. And that focus on improving multidisciplinary care for people with mental health challenges is also taking place across the country, supported by the ongoing goals of the long-term plan and the mental health investment. So over 1 billion since 2019 invested by NHS England. And that's now resulted in 370,000 people receiving care in those integrated models of community care. For example, in Somerset, the Open Mental Health Alliance, which includes NHS and voluntary sector organisations working together, means that individuals with SMI are receiving the right support at the right time. That includes personal finances, benefit and debt support, support to be socially connected, continuous crisis support. And that system has shown that between April 2019 and December 22, and I obviously did ask for updated data and they weren't able to give it to me in time, but it was good till December 22, was a 15% decrease in emergency department mental health presentations for adults and a 30% reduction in all age admissions for those with mental health need. So I could go on, but Layla would be very cross with me. But people can ask for further examples. I've already seen Nicola Easy talking about the regional adjustments, digital flag. There is a huge amount of change in maternity, as Layla's already discussed. And we're all, of course, very aware of targeted lung health checks, which has shifted the diagnosis rate against index of multiple deprivation, so that you are now more likely to be diagnosed early if you are on a index of high multiple deprivation than you are if you are a privileged person. So we know that by putting these approaches together with the right local intelligence, the right data, the right operational intent, and the right cross-functional teams, we can make a massive difference. Clearly, there is also loads more to do. We have huge performance challenges. We know that we are fundamentally often at the front line not delivering the kind of care at the kind of speed that we would like to do. I'm absolutely convinced that if we can figure out those local interventions that are really working for a particular community, and work with health innovation networks and all of the other communities that are putting these things together, if we can figure out a more effective approach to scale that, we will be improving our performance as well as meeting people where they are and addressing health inequalities, which are really top of our list in terms of improving the service that the National Health provides. Thank you.
Brilliant. Thank you so much, Emily. And now let us do a little shift to hear about the patient perspective, and who better than to tell us such things than Chief Executive of National Voices, Jacob Lent.
Thank you, Layla. Hi everyone, I'm Jacob, and if you've not come across National Voices before, just to briefly explain, we are a coalition of 200 health and social care charities, covering all your sort of usual suspect condition charities, but also a lot of community group organisations. So those who are working with the people and the communities who are most affected by health inequalities, who are having the worst experiences and the worst outcomes in terms of health at the moment, and very much are living their lives in poor health, and are dying younger. So the topic of health inequalities runs very much at the core of what National Voices is all about, and trying to make sure that the system improves. I'd like to touch on the concept of trust in my opening remarks, because I think I've heard many more eloquent speakers talk about trust as a determinant of health inequalities. So the Race and Health Observatory have talked about that. I think Victor from Confed's talked about trust being a really important thing to consider. And I'm going to take trust and look at it through the lens of making every contact count, which was part of the title of this session. When we think about trying to make every contact count, we might tend to think about that from the system's perspective. How can we drive efficiency and productivity by making sure we're doing everything we can to get the best outcome in that one interaction? But in order to do that, we really need to actually look at every contact from the user's perspective. And I'll take a couple of examples to talk this through. So if, for example, I am a deaf person and I'm trying to access the NHS at the moment, we know from one of National Voices members, Sign Health, they talk a lot about the really poor experience people have trying to book their own interpreters, that their communication needs aren't routinely considered in their consultations. And actually that is not just a frustration, that's not just an inconvenience to people, it's a real genuine barrier to people getting the care they need. And it places a huge burden on the patient to actually make sure that their communication needs will be met, not the system. What that leads us to is a world where we create poor health-seeking behaviours, because that deaf service user, that deaf person may not want to try and get an appointment to talk to the NHS about their health needs because it's going to be just too hard, or they're not going to get the help they need, so they put it off. And that poor health-seeking behaviour is really bad because their concerns, their problems won't be picked up early enough, their health outcomes will be worse as a result. And so we really need to think about remembering things like people's communication needs, a really basic support need that we could provide for people consistently at every single contact, yet we don't do that sufficiently and consistently enough at the moment. Secondly, when we're having a contact with a patient, it has to be on the patient's terms. It's not on our terms. So we might want to we've got a system challenge around obesity. We know that obesity is causing all sorts of underlying health conditions for the population. It's a growing problem, and we need to tackle it as a country and as a health service. But that doesn't mean that every contact with a patient who is overweight, we should be talking to them about their weight, because it makes every interaction about that. And it will create, again, those poor health-seeking behaviours. We need to give them enough information that they understand the risk factors, and we need to give them enough information about the support available to them. But then they can come and seek that help about their weight in their own time and in a way that works for them. If we try and force it upon them, as I say, they'll disengage, and that will be bad for the individual and bad for the system, because they won't be accessing healthcare at the earliest possible opportunity. But if we approach every contact by remembering the basic things that our patients need, and we do it on their terms, we can build trust and we can build good health-seeking behaviours. And that will lead us to a position where we can drive more efficient interactions with our patients, and the system does benefit as a result of that, and we improve outcomes for some of the people who are having the poorest outcomes at the moment. The problem is that we don't measure any of that good outcomes, that good experience, as a success measure for the NHS. We tend to measure things like number of appointments and outputs and things, and that doesn't incentivise. So go back to the deaf patient, for example. If that deaf patient has 3 GP appointments to get the help they need because their communication needs weren't met, when you step back and look at that at a macro level, that's 3 appointments. That's better than 1 appointment, surely, because we've done more appointments than ever before. But actually, the outcome and the experience for the patient and the clinician was not good, and from an efficiency point of view, it was not good. So I think we can, if we build trust, and then we try and measure the success of the NHS by looking at our outcomes and our experiences rather than our units of activity, I think we can significantly shift the dial on health inequalities.
There you go. Inspiring words. Thank you so much. And let us go to our fourth speaker now, who is Aruna Garcia.
Hi, everyone. I should also add that I'm chair of the Primary Care Network for the NHS Confed, so I wanted to just bring in that perspective as well today, if that was okay. So, really interesting, actually. So, I think that it's all come from COVID, hasn't it? In a way, I don't want to go beat that drum, but there's something about making sure that we've respected what we discovered through COVID, that sense of there were people that weren't accessing care, there were health disparities, that acute understanding of our communities and populations that our communities and areas in our system that weren't able to access care, or they were coming out with poorer outcomes. And if you think about the sort of vaccination uptake and the variance of that. So from the perspective of primary care, I think the question wasn't just health inequalities, it was about secondary prevention. So how can we detect disease? How do we make sure we monitor it? And how do we prevent that progression? So there was something a little bit about that too. And I think that's what probably we do best. If you think about your GP, if you go to your GP, they might talk about your weight, they might talk about, let's check your blood pressure while you're here. They might, so that opportunistic screening is absolutely brilliant, and we do that well in general practice. We also do, if you do have hypertension, which is a secondary prevention bit, we will make sure that you are monitored with our system. So you are on a register, and you will be invited for a health check, for a checkup for your hypertension every year. And that's called a quality, for those of you that aren't GP, quality and outcomes framework, which we do relatively well. It fell slightly in COVID because we were busy vaccinating, but that got brought back. The issue about health disparities and inequalities comes in with what we used to do, which was those people that didn't turn up, it's the was not brought, or the missing patients, or the DNA. And I think what we've learned is that they're the flags for telling us that there's something else going on. And I think what we need to get better, or we are getting better at, and we can see the culture developing, can't we, is that there is usually one sort of approach that we do with most, but we recognise that we may need to personalise to communities to meet some of their needs and try and break down some of their issues that create inequalities and create disparities. And there's something about personalising to patients, and making sure the conversation is about patients owning it when they can, patients owning their data when they can, patients, and making sure that the decisions are shared. So, and there is a culture shift in that is happening as we speak. The second thing that's happening in primary care, of course, is the primary care networks, and they were born out of the long-term plan with the idea that we would think about prevention as it's at its core. We would think about proactive care, so that sort of sits quite nicely within secondary prevention. So the idea was that we weren't just detecting, but we were actively treating, and we were also trying to prevent the exacerbations at the other end and anticipating if they were going to come about. I think one of the things that we touched on was a little bit about the data-driven approach and understanding. So it wasn't just something we were feeling or something we were experiencing, but actually using data to tell us what was going on. And that population health approach is something that primary care networks have adopted to stratify a certain occurrence, for example, vaccination, and then understand the cohorts that might be sitting under there and segment them, essentially, so we can start to do that personalisation. So that's as good as the data that you've got, and at the moment, isn't it? So the data that we've got is mostly primary care data, and I think there is a way to go to get that data to reflect the whole patient journey, and also in some areas they've brought in social care. So there's some really rich, in some areas, some really rich data to start thinking about proactive care and start to do some predictive modelling, in thinking about suicide prevention. We can, there are systems out there that are able to track patients and understand when they're flagging for suicide prevention at the moment. So So I just wanted to, and I think that and digital and data are slightly different. I just want to make, digital's great, which is the software, and making sure we've got those things that are available. I think I just wanted to touch on, because I could go on, the touch on was the community bit, which is the difference that's happening in, one of the other things that PCNs are doing is that we are connecting with our communities, and we are developing so it's not just the patient, but the patient in their context, which goes on to reducing health inequalities, right? So there's something about actually going back to where the patient comes from and meeting them in their space, rather than thinking they've come into my space in my surgery or hospital. So if I understand your family, I understand who you live with, I understand what you do, and whether you've got some space to exercise when I ask you to exercise for 20 minutes a day, if I diagnose you with depression, right? And things like that. So, and developing those community connectors. So we have primary care networks have started to, and it's varied, it's not everywhere, but they've been doing some great work to work with communities and develop alliances with community champions, develop alliances with voluntary care sector organisations, which is what we've heard about a little bit, to create bespoke packages for care, and that sort of secondary prevention that I was just talking about. So, and starting to, I don't know how many of you have heard of the Brazilian model, but knocking on the doors of those that we don't see, actually. So going out and outreach, active outreach to those communities. So it's a really different space to be in. It's a really challenging space because it's not a traditional model. And what we want to be making sure is that we're operating as a team of teams. So this is not just making every contact count, but making sure that we have an integrated approach across whichever partner you interact with, as a patient with hypertension, for example, or a patient with learning disability that needs a health check.
Amazing. Thank you so much. Hasn't it been such a treat to hear from all those different perspectives on this incredibly interesting topic? I'll ask a couple of questions, and then I will go to a bit of Slido action. There are already quite a few questions in there, so if you're feeling inspired, then get those questions in now. If you don't like Slido, then brace yourself, and in a minute I'll ask you to stick up your hand. But let's see. I had a couple of questions to kick it off. And we just heard from Aruna there some interesting things about lessons from COVID. And Emily, of course, you have lots of lessons from COVID because of all your work, including in the COVID vaccine. What do you think you learned from that experience that you can really bring into this question of secondary prevention?
I think a couple of things that have been mentioned, but I'll amplify them. I mean, the first, I think just picking up on your last point, is, which I really learned from both communities themselves and from Michelle Kane, who led this work in the vaccine program, was about letting communities design the services that they needed. And I'm not saying we did that flawlessly or from the beginning, because we didn't, right? At the beginning, we had to get a standard model of service out really quickly. And so we did something that was going to work from that perspective. But increasingly, as we had more capacity and more ability to engage with communities, we changed the way services were delivered based on what communities were saying they needed. And actually, relatively early on, given the first vaccine was delivered on the 8th of December 2020, it was kind of early January, we were engaging with imams about what it would mean to have delivery that would work for Muslim communities. So it wasn't that far off, but it was still not the first thing that we did. And we had some freedom to operate that way, and we didn't have others. So the other thing we did was to be straight and say, look, we can change the model to this extent, but we actually can't change it to that extent, either because it wouldn't be safe, or because it's not economic, or because it won't actually be fair to other communities. So really trying to find out what's the effective balance between what a community needs, the way they actually express that, which may not be exactly the same thing, and then our ability to flex delivery models accordingly and make sure that meets all of the other conditions that we have on them. I think when people used to say to me kind of 3 years into the pandemic or 2 years into the pandemic, let's start planning to go back to business as usual. And I kept saying, why would we go back to business as usual? Can we just keep doing this? Can we just keep doing things better? That was one of the things that I meant. I do think it's really hard every day for lots of reasons, but that was one thing. The second thing is data. I mean, not just directed at inequalities, but we ran the vaccine program starting at 8 o'clock every morning with a review of what we did yesterday at lots of different levels, not just how many vaccines we delivered, but where we delivered them, whether there were particular DNAs in a particular community or a particular location. We looked at all the PCNs across the country to see which ones were struggling, which ones were ahead of their targets, etc. So, and that then helped us make better operational decisions because we could actually see what was working and what wasn't working. The third was this innovation point. So I was really struck in a visit I probably did sometime in about March to a group of PCNs that were vaccinating together in Slough, where they were managing the flow of patients into what was a leisure centre in normal times, both by the right PCN vaccinating the right people, but also the fact that there were cardiovascular tests on offer, so they were measuring people's heart rates and looking for arrhythmias, etc., in a population that was largely Southeast Asian origin and therefore at higher risk for hypertension and other cardiovascular diseases. And that was not something we'd suggested, that was something that they had created. They'd worked with the local council to create the right space to do it. And so I do think this is the challenge I've taken into this job, which is how do we facilitate that without trying to control it? And how do we make sure that innovation happens safely, happens in a way that is scalable? And I think the final point, which is, I'm probably going to misquote Steve Jobs here, but it's what people tell you they want is not necessarily what they actually need. So I think we do have to really listen to the feedback we get, and we have to recognise that, you know, by use of data, by use of extraordinary experts that we probably only have once or twice nationally, we will know things that we then have to make fit for local communities rather than them being designed bottom up. Both things need to be true. We need to design services that respect all of those perspectives and respect the data and are appropriate value for money, as well as being safe all the time.
Brilliant. Makes a lot of sense.
I hope it makes sense.
And yeah, I mean, I think it's really inspiring when we can take those lessons from when we were required to do things in such a speedy, agile, different way, and bring them in this way to be effective. Now, I see that there's a couple of questions that lots of people want me to ask, so let's go for it. The first one was initiated by Amanda Davey, although there are many people who have liked it thus. How can we work within the constraints of the measures that we have to report on and system priorities to make the shift to what matters for you, for patients? Actually, in some ways, these two questions that are particularly popular are fairly similar. So I'm going to read out both the questions, and then perhaps we can get your different reflections on them. So that was one. And the second one, how do you prevent every contact with a healthcare professional from feeling like a tick box exercise and from making patients overwhelmed by all the questions and information? So both of those are how do we deliver all these many opportunities of driving brilliant secondary prevention without overwhelming patients with tons of tick box action and really making sure that we're focused on what matters to them. Who fancies going first?
Well, I don't mind starting. As a clinician working in a tertiary hospital, as a senior clinician. There is the ideal and then there is the reality. The reality for us as healthcare professionals is that we are overburdened, we are overworked, and we are trying to deliver higher and higher standards of quality care, and yet not necessarily having the time, the space, or the resources to do it. So I think it's important in answering that question that we must understand and appreciate the current landscape that we are in, which is that we are burnt out, and yet still wanting to deliver high quality care. So I would say that the likelihood that we are overburdening our patients is probably, in this current juncture, quite unlikely. And that is because we probably only have, 8 to 10 minutes with a consultation. Yet there is the desire to try and deliver as much information as possible. So what I would say is that the best way, if we can, is to start the consultation by asking the patient, what is their aim? Because this helps guide and curate the rest of that consultation. Now, their aim may be separate to what, I think as Aruna was saying, our aim may be. But actually, their aim may be the biggest priority and actually what they came in with. And so then to answer the first question about how can we make the data work with the limited data points that we are given? I think that's the source of the question. Well, we can use those limited data points as the foundation upon which we can then create better frameworks to collect further data. Often we can allow perfection to be the enemy of the good. And so we don't collect any data at all if we don't think we don't have a perfect framework. And I often find that whilst we all have particular biases and particular lens through which we can see data, and therefore if we don't see any positive outcomes in the data, we can dismiss it. And yet there are always hidden insights, even in minimal data points. But the last thing I would say is that from a clinician perspective, we are woeful at inputting data in the first instance. So we have electronic patient records, I'm sure most of you do, and because we are overburdened and overworked, we don't actually populate the particular electronic patient records well. So therefore, the data that we have remains poor. So in all of what I'm saying, we also have to find some time to populate these data sets so that when we then want to extract from that data, we have something good to extract.
Thanks, Christine. Emily, what's your reflections?
I was going to say, I obviously would agree with all of that. I think there is a role also for, whether it's NHS England or the, the private companies providing some of these systems, etc., is to make it easier to put the relevant data in so it doesn't feel so much like a box tick. We can always streamline these operational processes, even if the first one is a bit clunky. If you watch somebody using it, you can say, right, that's not working, I'm going to do this other thing. And I was absolutely horrified when somebody told me about an ICU which had put an EPR system in, and the clinicians were using bits of blue paper to take notes because the iPads that they needed to put the data on in the ICU weren't charging properly, and so they were writing. And that's a terrible use of everybody's time, plus probably not safe. So there is something about making sure the actual data systems are designed to be easy to use, improving it as you go, but then particularly, which I think is partly your point, make the data usable for the person who's putting it in. I think we really often design the data collection for the person who's going to assure the process, or the NHS England person who needs to know how many beds are occupied or whatever. That may also be a really important use of it, but if it's not useful for the person who's putting the data in, then what is the incentive for them to use it effectively? So I think we have to look at these end-to-end processes and absolutely do all of that and make the data systems themselves much, much easier to use.
Brilliant, absolutely. Actually using the data that you're collecting is so key, isn't it?
Exactly.
Like, I think I'm always struck by the amount of data we collect versus the amount of analytic skill and capacity that we have to really make the most of it. And I think, as we move forward and we do get more of that, then this will all become much more of a meaningful exercise as well, once as these opportunities arise. Aruna, I'll come to you last, obviously, because this is quite a patient thing.
Right.
Aruna,
I'll be quick. So I think the system priorities are interesting, and I think there's a policy conversation and focus conversation, because this is about that prevention agenda, and it being not a nice to do, but a business as usual, right, to get it right, if you think about it. And at the moment, if the tick boxing is the reactive system priorities, we are a bit stuck, and we're all in the same boat, remember? But there is something about the fact that the impact is going to come from secondary prevention. If 40% of our long-term conditions are preventable, and we know we've got a cliff edge coming up in terms of a demographic and complexity in long-term conditions, we have to do it for sustainability. So there's something about getting that right. I think in terms of the data entry, coming from primary care and with quality and outcomes framework, we have to get our data entry right. Ask any GP. Filling a template is one of the hardest things that we do. But coding and tick boxing that you've given, that's I agree, asking it a million times, and I'll come back to that in a second. Is something about is ensuring that we've done that. But actually getting the data right is super important to be able to pull that out later on to inform those missing patients and those missing cohorts. So there's just something we need to think about that together. The bit about what do we do if I don't want it, right, I think it's about personalization. This is not, it doesn't have to be about tick boxing, does it? It just has to be about, have I given the information to the patient in the right way at the right time, but made sure that they understood it. And that may be something about knowledge within the community. I might not be the right person to give that information. Remember, in primary care, we've got our additional roles. So I have a whole host of roles of social prescribing link workers that I can refer to have a chat that is non-threatening. So it's not from a GP, it's actually from somebody that is non-threatening. It's just, have a chat about, do you think you want to be a bit healthier? What do you think you might want to do? What you eat, etc. So there's something about getting that bit right. And I think the last bit I want to say about not doing it, I'm just thinking about the health disparities that exist with severe mental illness in the core 20+5. And if you look at their access in terms of being able to attend for health checks, if you look at their screening in terms of cancer checks, if you look at blood pressure, weight, etc., they don't attend, all right? And there's something about, and I agree with you that they might not want to be asked, they might say no. I think I'd challenge that with, have I engaged them in the right way?
Yeah.
Is it a different conversation? Is it a different approach? Do we go, is it that this way, the way I do it normally doesn't work, and there is a personalised way with that group of people or with that person that I need to change to? And I think that agility and that flexibility is what we're understanding to try and reduce those health inequalities.
And Jacob, does that resonate with you?
Yeah, I think that agility and flexibility is essential, because that's what allows you to personalise an interaction and avoid it feeling like a tick box exercise. I think that the thing that's been kind of running through my head on the sort of the whole secondary prevention conversation and how to sort of and linked to this is around the point of diagnosis. So we published a report yesterday on diagnosis. And one of the things that really jumped out at me from all the work that we did on that was that people were being diagnosed with a whole range of different long-term conditions and being given some medication and a leaflet. That was sort of their experience. They didn't have any there was no sort of consideration of the capacity of the patient to learn about the condition, or where they might go to for more information and advice, or how to access peer support, or even how follow-up like medication reviews should work, how repeat prescriptions should work. We need to be providing more of a wraparound support at certain points in pathways, I think, and that stops that interaction feeling like a tick box, but also future interactions. So many patients will talk about medication reviews not actually being that particularly useful for them. It's actually a hindrance because they just want to keep getting their prescription and living their lives. Actually, it's a really important checkpoint, but because we haven't explained to them why it's useful, why it's important, it feels like a tick box, and we can't make the most of it. On the outcomes question, the other part of the question, like how we measure that, I think we should just ask patients more whether we're delivering the outcomes that they want. If you look at all the patient surveys that we ask at the moment, they're not very outcome driven. They're like, did you get an appointment in a particular time frame? Did you see the clinician you wanted to see? Like, that's helpful information, but it's not the whole story. So we should just be asking patients if they got the outcome that they needed from each interaction. You don't have to ask every patient, a sample will do, but we need to be asking that question more frequently.
Brilliant, thank you. There's a few questions here, of which is a sort of general workforce theme. I might go for Christine and Aruna for this one, which is, what do you think the clinical workforce needs to be able to make the most of every interaction counting, particularly in this context of delivering good secondary prevention?
Yep. Do you want me to go?
Go for it.
Yeah. Okay. So it's a brilliant question, isn't it? Maybe clinicians amongst you, maybe I'll ask you what you think. So it's, you know what, there's something about education and us valuing the bit about prevention. I think I spent, thinking anecdotally, I spent a long time thinking about prevention as a nice to do. I was a good doctor if I said, do you want to stop smoking? And I was a good doctor if I remembered about mental illness and those lifestyle factors, etc. But I would put it to you that it's a necessity, and so that's the first thing. There's a shift in the dial for us in terms of clinically understanding prevention. I think the second bit that I would say is that, yep, make every contact count, brief intervention's great, but it still feels a bit mechanical, doesn't it? Which is what you're saying. So maybe there's something about how do we use the staff and the structures that we have to meet patients where they're at, to have the conversations that make sense to them in their communities, because there will be different conversations around the country. So how do you make it local whilst delivering that priority? I think that's really, really important, and recognizing there's a person in front of you that you're personalizing to. I think the third thing I would say to you, and I'm sure my colleagues would say, is time. And so that bit, you know, we are pressured within a consultation these days, you know, filling in templates and data so that we can use it later, getting the referral. We're doing so many different things. And that may be about using your team and thinking about the system as a resource wisely. So your contact might just be, you know, I noticed this, do you want to have a chat? And then you've got sort of, you're using your ARRS roles. Your secondary care person might have a sort of referral into a lifestyle hub, etc. But it's that ease of moving between it and acting and being responsive with it. So, and then I think finally is that permission to be an advocate for prevention. We all know it, right? We all know it, but we feel like we've just heard, actually, system priorities. We're busy being reactive because we think that's important. But actually, if we're the voice for our patients, and we know our patients want to feel healthier and feel happier and feel more and whilst they've got their condition, feel more in control by themselves, so activating patients in their communities, why can't we do it?
Thanks very much. And Christine, if you could be quite succinct, because we better take a couple of questions in the room before we finish as well.
I will be succinct. I think Aruna really very much has touched upon one of the main points, which is time. But one of the additional points, is that we need to be more curious about people, and we need to understand how we have changed through the pandemic. Our social networks that ordinarily we would use as support, as mental health support, as people to bounce off in terms of advice, have gone. We have an underlying level of anxiety that is now being manifest as health anxiety. I think if we understand that, it allows us to engage with our patients in a way that takes them as a whole. That requires a curiosity about individuals, about people, and some of us are better than others. We all have different skill sets. But I think just understanding where we are as a group of people and how the effects of COVID still remains with us very much today.
Brilliant, thank you. Now there's two questions I've seen. This gentleman here and this person who I can sort of see over here. Let's go for that.
Hello, my name's Tony Johnson from Health Watch, and I'm sure you're all doing a wonderful job, but I come from the point of view that we should be starting by ensuring that there's publicity and good news stories to help people not get into it. The media would play an enormous part if the NHS engaged with the media and actually provided some help to ensure that people didn't get into this situation of obesity. Now, what I'd like you to know is how else would you actually help to improve the situation? And this goes for all health issues. We want to be able to stop and reduce the incidence at its beginnings, whether it's cancer, start at the beginning, to ensure that people are picked up and the x-rays and the scans are done and read by AI so that we get reports. Because too many times I'm finding people who have had problems where the scans have not been read properly, and we also need to ensure that with dementia, for example, that people are picked up at an early stage And I think it's wonderful that there is the opportunity for perhaps doing blood tests, and let's hope that we can actually address. We should be looking to save money to help to improve the health service. It's not just of rattling the begging bowl. Sorry.
Leila, I'd like to take that question. Thank you very much. I think, in a way, there are three aspects here. The first is about health education. The way we consume health education has changed. So some of you may know I have a monthly radio program on BBC, for example, focusing on women's health. We have medical influencers, some that are very good and that the NHS works closely with. So we need to understand that the way people consume health education and access that is different. So that in one way helps, but there are some risk factors that are almost immutable. So I'm talking about pollution, I'm talking about housing, of which the individual will have very minimal agency with, and we are only now just understanding the impact of. So this is where wider health policy comes in. And then thirdly, it's about access to good health services. Now, I work in an amazing trust in London, but it has funding, it has money, and this is not necessarily the same and evenly spread across the country. So we do have to understand that and then help those people that are in areas where access is difficult, and the quality and delivery of services is also different. So yes, there is the impact and the agency from the individual, but it's much more wider than that.
Yeah. Thank you. All right, your question?
Oh, thank you so much for this afternoon. My name is Huzaifa Adamali. I'm a respiratory consultant. I wear many different hats. One is an educator, number 2 as a clinician, and 3 as a researcher. And the final one is an advocate for addressing health inequalities. I would like to get thoughts from the panel. Is one of the things that I think we should be really advocating is the decolonization of the medical curriculum. We in the NHS are going to be getting young doctors who need to know about health inequalities among all populations. And I think we should mandate a curriculum that's fit for purpose in the United Kingdom. Number 2, comments from the good general practitioner. The thing is, our modeling of care delivery in the clinic is wrong. I get 20 minutes for a return appointment and 40 minutes for a new patient. GPs get 10 minutes. Sometimes when a patient from an ethnic background comes, I'm trying to get onto language line, trying to find that interpreter. Number 2, trying to explain the information. And number 3, being in that advocate you talk about. Surely we are not fit for addressing health inequalities with that kind of modeling. I dread to think when I 10 minutes with my GP what he or she does. Should we now nationally having a conversation that if you have a person of ethnicity, we should be considering longer appointments that will allow that individual to develop that relationship and get that information?
Emily, what sorts of conversations happen in that sort of question?
Well, I think that there are obviously multiple layers to that, and the review of clinical curriculum, the training, etc. Colleagues on the stage may want to talk about, but that happens on a regular basis. But the kind of systematic overhauls obviously happen on a more sort of periodic basis. I think the broader point I'd want to come back to is, which was in part of what you said, is we now have so much more insight into both the sort of patient experience and the underlying drivers of health and the broader societal impacts on health and the intersection of all sorts of factors around deprivation, not just health inequalities. That I think there is absolutely an opportunity in broader health policy to say, what should our models of care look like for the future? So NHS England is working to try and ensure that care, as we oversee it, happens in the right place for the patient, right? We end up, as we know, with far too many people in A&E because they either haven't come forward early enough, or they haven't been able to access care in primary care, etc., or potentially their appointment didn't pick everything up because it was only 10 minutes, etc. Enacting that involves quite profound changes to how clinicians deliver care, our societal model of what care looks like and what people think about GPs and the role that GPs play. It involves absolute transformation on digital models. It involves supporting all of our clinicians with better data and AI tools so that they can make the most of their time. One of the things we've seen, for example, recently is the ability of AI to write discharge letters from acute care, which are pretty close to not needing further oversight clinicians, even though obviously at the moment they do. This is about looking, as you say, both at the fundamental model of how we deliver care, which will take quite a long time to shift, and at the very micro level of how we're delivering care every day and the messages we send to the public about where is the right place for the particular care you need, and about prevention, back to the previous question. All of those things need to come together. In my role as Chief Operating Officer, I'm obviously quite focused on the day-to-day, which is how can we make improvements in all of the pathways we're doing. And with an election and a potentially new government, this is an opportunity to say, right, if we're thinking 10 years from now, what are the changes that we want to start making collectively? Won't just be the health system, because a lot of these are not delivered solely by the NHS. What are the changes we want to make across all of those pathways, and how do we start walking towards it? And obviously, medical education will be a big part of that. I think what we need is that direction that says this is the systematic change we need, and these are all the ways in which we're going to deliver it. I appreciate that didn't quite answer the question, but it was at least hopefully a discussion in the same area.
Thank you, Emily. And folks, this has been a fascinating and wide-ranging conversation that's hopefully given you all sorts of things to ponder. I'm afraid that we are out of time, which is so sad because there are so many questions, and I hope that you'll continue having these conversations outside of this session. We'll just finish by thanking all of you for your brilliant questions and thanking our wonderful panel.
Thank you, Lena. Thank you.